Hello and welcome to Live Healthy West Virginia, the podcast brought to you by WVU Medicine, aiming to help everyone live a better, healthier life in West Virginia and beyond. I'm your host, Mary Ravazio Menard. Pediatric epilepsy is the most common childhood brain disorder in the U.S., with 1 to 2% of children under the age of 17 diagnosed with epilepsy. The disorder causes recurring seizures triggered by abnormal electrical and chemical changes in the brain. The good news is there is a growing number of treatment options for pediatric epilepsy, including new medications, surgical advancements, and neuromodulation therapies. So today we're talking about pediatric epilepsy with Dr. Lawrence Morton, Chief of Child Neurology at WVU Medicine Children's and the WVU Rockefeller Neuroscience Institute. Welcome, Dr. Morton, to Live Healthy West Virginia.
Hey, thank you very much for the opportunity to talk. I'm excited over the possibility of being able to go through this and maybe explain a little bit more how this important field of pediatrics has been changing and evolving.
Yeah, that's what we're going to be talking about today. Great to have you. So let's start with the basics. What exactly is pediatric epilepsy?
Well, I think we have to start more fundamentally with what comes to mind when people think about epilepsy. And you said recurrent seizures. So again, some things people may find is seizure disorder is another term they might hear. If grandparents might still use older terms like fits, for example. And so we just have to all get into that category of what is epilepsy or what is a seizure disorder, and there's no difference between the two. People used to make a distinction that epilepsy was recurring seizures and you didn't know why, and there was no specific trigger, while you could have a seizure disorder in people who had something predisposing like a brain injury. And I think to remove some of that confusion, it's now completely come under it. Then we have to say, as we look at epilepsy, are we talking about what people may see or what may actually be happening in the brain? And then are there things that are distinct and unique to children, which give you a preview, yes. But when we think about what a seizure looks like, most people still will tell you people fall to the ground and convulse. That's actually no more than about a third of seizures.
Oh, okay.
And most of them are non-convulsive, and it'll be just people will suddenly become unresponsive. They may lip smack, they may turn to the side and have repetitive small behaviors and not be responsive. And that's actually the most common. Another thing most people are not aware of, as particularly when you talk about the convulsive seizures, is about 2/3 of all seizures are associated with sleep. So in fact, they're not happening when people are awake. Oh. And more of those are convulsive. So sometimes it can even go unrecognized by families because they hear something and by the time they go into the room, it's over. And, you know, I've had families where they figure out later that dad or an uncle had seizures because they figure out in the child, and it's one that runs in families. So now what is happening at a brain level? You know, that's another thing where where concepts are changing.
Okay. You
know, I think that we readily accept the fact that our brain works like a computer network, and that's a great analogy. And you know, much like a computer network, the information flows between different devices. So when people would say, oh, we only use, like, you know, one of the famous kind of myths that you see pop up in science fiction is we only use 10% of our brains. Right. Well, that may be true at any given moment, although 10% is probably a low estimate. But if I am playing a musical instrument, I'm using very different networks than if I am hammering a nail or playing golf or listening to someone or speaking now to you. Yeah. And so there isn't one area where those functions live in the brain. It's tying everything together. So when people say they know they're going to have a seizure because they get, you know, a sense, they smell something funny or their stomach feels funny. Yeah. You know, that's triggering one of those networks, and then that spreads. So the whole concept of seizures being a network phenomenon, and one area is just like we have an area that helps us understand speech, But to understand speech, we have to tie in memory, emotion, etc. I mean, if you don't learn a vocabulary, you can't understand it when it's spoken to you. So the same thing with seizures. We may have an area that corrupts or that network, but it's a network phenomenon. And
that's a good analogy.
Now,
that's a good analogy.
But children are
yeah. How is epilepsy different in children as opposed to adults?
Well, sometimes it's not.
Okay.
And that's very important when we get into what our treatment options are. But there are unique seizures to children.
Okay.
Some of them we think of as the common, what the new term is self-limited epilepsy of childhood. These are seizure disorders that tend to run in a family, and it almost has a pre-programmed age that it turns on, and an age that it may turn off in most instances, but not all instances. And some of those we think of, the older terms would be benign Rolandic epilepsy or childhood absence or petit mal seizures. Then we also have that they are unique and often quite difficult to treat seizures unique to infants that start. And these are the new term now is developmental epileptic encephalopathies. And what's meant by that, it's a term of convenience, which is you start having seizures at an early age, and it can have an association with very severe impact on normal development. The self-limited epilepsies I talk to, by and large, these are developmentally normal children, though they can still have challenges in school, which we can go into. But really the main difference that we find is some of these specific entities unique to children.
Okay.
And our time to intervene is potentially during childhood. The reason I want to emphasize that more than half, though, are very similar to adults is that to bring new treatments to children, and you know, again, we can talk about treatment in its own category. Is that years ago, if you wanted to bring a new medicine on board, you had to do completely separate studies in adults and children. And that sometimes led to a delay in getting new treatments to children. Simply because, again, there's a lot more adults with epilepsy, just because childhood kind of ends, depending on how you define it, at either 18 or 21 years of age. And many of us enjoy a lifespan of 50 or more years past that. But the FDA then finally acknowledged that if you can say the seizure disorders are pretty much the same in adult and children, if you get it approved in adults, if you can prove it works in adults, you don't have to prove it works in children. You just have to do smaller studies that look at safety and evaluate how you should dose it, because we have to dose children differently than adults. So the reason I emphasize that part of it is, in the last several years, that has allowed us to get some of the newer treatments to children much faster.
Well, then let's move over to how you diagnose epilepsy in children, because I understand there's some newer testing available.
And this is where we get into, again, a lot of it is just definitions.
Okay.
You know, if we put seizures aside for a second, you know, how do you diagnose a headache? Well, people tell you they have a headache. They tell you their associated symptoms. And if you say, well, do I have a brain tumor, which is very rare in headaches, but almost everybody asks that question. Well, that you need imaging, but that's not a diagnosis of a headache. That's a diagnosis of why. And in certain ways, that is true of seizure disorders or epilepsy in children. Sir William Osler, who is considered sort of the father of modern medicine, who practiced in the 1800s, once said, listen to your patient and they'll tell you their diagnosis. And what that means is everything starts with just taking a good history. If you actually know the questions to ask and can get families to tell you, you can say with a certain degree of certainty that's a seizure. What's changed is the why, though I want to put one kind of wrinkle in that.
Okay.
Sometimes we get descriptions of spells, we don't know what they are, and now everybody has a cell phone practically.
Yeah.
So we do encourage people to video, and, it's been looked at. And if you're not sure, about 2/3 of the time, being able to see a home video gives you the additional information that you need. So yes, in terms of just making the diagnosis, was that a seizure? The biggest breakthrough hasn't been medical technology, but in fact, mobile phones.
Oh, wow.
But when you talk about why, that's where there's been exciting changes.
Okay. What are some of those changes?
If you have a child who's been developing normally, who develops seizures, the paradigm used to be, we're going to do an EEG and look for it, and then do an MRI of the brain, or a CT and then or MRI. And if it's negative, okay, great. We've done our workup. Well, now we actually found that there are gene panels that are commercially available and additional genetic testing. And in fact, you're more likely to find out why in a combination of an EEG, because certain seizures have very distinct EEG patterns. It's like a signature.
And is the EEG when they put the
Yes,
electrodes?
I'm sorry. Thank you for reminding me.
That's okay. That's when
it's so much a tool of my trade, like a hammer may be to a carpenter or a saw, that I don't think about it.
That's
but the
okay.
EEG, which just literally stands for electroencephalogram, which is measuring the electrical activity that in ceph, the head. So measuring the electrical activity that's happening in the head. And we have normal patterns that are age dependent. So for example, a baby is going to have a very different normal background EEG than a 2-year-old or a 5-year-old, and very different from adults. Certainly as you get in past about 8 years of age, the differences are more subtle with adults, but first years of life, very different. And we can sometimes see markers for a seizure disorder on it, and we call them spike and sharp waves, but they can have very specific patterns that can sometimes give us. That's, for example, what I talked to, self-limited epilepsy with centrotemporal spikes, which used to be called benign Rolandic epilepsy, which runs in families, or childhood absence or absence epilepsy, or petit mal seizures with the old term, where they simply stare. These have very, very distinct patterns. And some people would say once you have it, you don't even need to go further. But what we have found is in the child who's either been developing normally or in those early infantile seizures, the MRI might be helpful, but new genetic testing is actually higher yield. So in fact,
better indicator.
And so in fact, in many ways, it's once you have a diagnosis of seizures in a young child, it's an EEG and genetic testing.
Wow.
But one caveat to that. If you find a child and you're like, oh, I'm looking and they're not moving their left side as well, and then you're looking for an injury that might have predated birth, that's where the MRI is helpful. But in a child who doesn't have any of what we call focal findings on exam, the MRI might be important, but it's taken on less importance than it used to. And these new testing, we're also still at the early stages of finding that there can be immune diseases that cause epilepsy.
Wow.
I think some of it was put under attention by, I believe it was a New York Times reporter more than a decade ago, who did their own story, Brain on Fire. And they had mental status changes, they developed seizures, and they found out they had an autoimmune condition called anti-NMDA encephalitis. Well, we know that can happen in children as well.
Oh, wow.
And the recognition that these things can happen have improved our ability to diagnose. And there are treatments that can facilitate that long-term recovery. Okay. So again, a very exciting time that way. Because a seizure disorder is kind of like, going back to the headache analogy, a lot of our medicines are like taking Tylenol or ibuprofen, Motrin for a headache.
Yeah.
It's treating the symptom. It's not treating the cause. Once you know why, as I already said with the autoimmune conditions, you're starting to get to the why and treat the why, and things get better as a result.
Yeah.
And to segue a little bit, we're really at the early stages of treatments for genetic epilepsies that get to the why. We already know in other neurological conditions, such as spinal muscular atrophy, which is a neuromuscular disorder that could be fatal by 1 to 2 years of age. There are now genetic treatments. There are now children who would have expected to be deceased by 2 who are 7, 8 years old and not just living, they're walking. There are now, for a specific type of epilepsy called Rett syndrome, investigational trials in genetic treatment. And the development down the line of medicine specifically geared to offset what the genes are doing.
Okay, so it sounds like there's not only better testing, but better treatments. So let's
some of them are on the horizon, but
okay.
Yes, some of them are here. But the exciting future is once you know why, we can actually not just treat a symptom but cure, and they're on the horizon.
All right, let's talk about what are some of the treatments that you're most excited about. I mean, there's so many to be excited about.
But if we start with almost always the first line treatment is medicine.
Okay, let's talk about meds.
And since the 1990s, we went from having 4 or 5 options by and large to now over 20. And some of them haven't necessarily led to better seizure control, but better side effects. So people can now get control and not, every parent's fear is to be medicated. And we're going to have to come back to that to talk about some of the baggage that can go along with having a seizure disorder. But in the last few years, there have been medications where, again, we've had people who have never been seizure-free their entire lives. We're not talking about children, even adults who are now having a percentage of them seizure freedom. One of the catastrophic epilepsies, one of those developmental epileptic encephalopathies, Dravet syndrome, that starts in the first year of life, often with seizures with fever, and leads to uncontrollable seizures, developmental delay in many instances. There are medications now. There is a lot of attention around that because when cannabinoids, medical marijuana, which is a completely inaccurate term, but one component, CBD, got a lot of attention on the internet because of a family that was providing that, and then that led to the development of medication called Epidiolex, which helped some people in ways they hadn't been helped before. But now, and going back to that better understanding of why the seizures are there, more recently, and I'm using this as one example, fenfluramine has been used in this patient population. You might say, fenfluramine sounds familiar. What is that? And it was half of a diet drug called fen-phen.
Oh, yes.
Now, fen-phen got removed from the market because there were some sudden deaths, and we are monitoring. We're not seeing it with fenfluramine by itself. But here it is, a diet medication that works on certain types of serotonin, is controlling seizures in that specific entity, because it's really correcting some of the chemical changes that you referred to in the introduction, rather than specifically suppressing seizures. And it really seems to work preliminarily right now in that population much better than any other seizure population. So we're getting into the beginnings of specific targeted treatment for different conditions. And as we learn more about the genetics and learn more what to do with the information that's giving us, again, more of these treatments will start to emerge on the horizon. But
so
what else?
It's ever evolving.
Ever evolving.
Okay.
The medicines, and then we also have other options now.
Yeah. What about when because I know there are some patients that are medications just don't work.
Yes. Now,
what are the newer options for patients in that position?
Well, first we should even think about how many people do medicines not work in.
Yeah.
And that can be as many as up to 40%.
Wow.
Now,
that's a lot.
Now, the why gets into at least half of those we think are avoidable. The people don't have, either they don't have access to the medicines regularly, or they are not able to take it as prescribed. But we think that solidly at least 15%. And now when you talk about a disorder that can be up to 3% of children, but even if we take 1%, 15% of that is, we're talking about tens of thousands of children who are not going to be capable of responding to medicines right now. We have non-medicine options. I think the one that most people have at least heard of is the ketogenic diet. And that really needs to be done with a nutritionist, and it's a very demanding lifestyle. So again, not always excessive, doesn't always fit into a family's life. But when successful, is really a very good option.
Simply a diet change.
Yes.
That's excellent.
And it's a high-fat diet. It's been known, I think it was the person who really popularized it was Stanley Kaplan at Johns Hopkins. We're talking about decades ago.
Okay.
But now we also, the most underutilized treatment in both adults and children for medically resistant epilepsy, which is really the term we want to use when drugs don't work, are surgical options.
All right. What are the surgical options?
And they'll fall into two categories. What is a curative surgery, where really the expectation is we're trying to make somebody seizure-free.
Wow.
And then the other is what are called palliative, where there's probably no more than a 10% chance of becoming seizure-free, which is still better than medicines at that point. And I want to come back to defining that. But really, it's just to relieve sort of a very heavy or catastrophic burden. Now, first we have to say, when is somebody medically resistant? And for a long time, this was really somebody's judgment. But now, again, through experience, there are professional definitions in the epilepsy community. And that's if you've been trialed with two medications that are appropriate, because sometimes we pick a drug for an epilepsy, and then when we learn more about it, it was never the right drug in the first place. That shouldn't count. Or they were uniquely not tolerant of it. That doesn't count as a trial. But if you're on two appropriate medications and still not the seizure control you need, you should be considered medically resistant. You may go on to more medication trials, but at that point, these other options should be very prominent in the discussion. And especially, again, surgical options, because after you fail two medicines, the chance of becoming seizure-free with more medicines is under 5%. So when I start talking about surgical options that are not expected to make you seizure-free, but they have seizure-free, but still 10%, that's still double what another medication will do.
Sure.
So now
So what are those surgical options?
Let's talk about the goals of care.
Okay.
And that's where we have to talk to each person individually. If you have a family member and a child who's been developing normally, and again, the hope and expectation is they can be fully independent as adults, go through school, graduate, get a job, live on their own, have a family of their own. Your goal is seizure freedom.
Okay.
Can't always achieve your goal, but your goal is seizure freedom. And then you are looking at what your options are. And if you can define that there appears to be one area of irritability in that seizure network, then ways of isolating that area and then treating that area. Now, we do that through the EEG we talked about, and then sometimes we have to do a different type of EEG where we actually implant the electrodes in the brain to really narrow that area down to a very small area.
Is that
That's not neuromodulation.
Okay.
We're going to come back to that.
We'll come back to that.
This is the curative to try to get that area as well defined as possible.
Okay.
And then we assess through other testing, including neuropsych testing, which is kind of an IQ testing, gives us insight how that person thinks and processes information. If that area, because it's been promoting the seizures, has lost its function, and can we either remove it, or what's happened now is laser ablation, laser thermal ablation, where through, again, a small hole, you can actually essentially melt that small area with a laser. But that's why, again, we have to have it so well defined to as small of an area, because again, we're not designed with extra brain.
Yeah.
And many of those patients actually can even they go home the following day if laser is an option.
Wow.
Obviously, if you do more classic surgery, which does have its role in some patients, a little bit more of a recovery. But defining that, again, in the appropriate candidate, we can see seizure freedom rates over 70%.
Wow.
So when you compare a medicine under 5% to 70%, really almost no comparison.
That's life-changing.
Exactly. There are now treatments like the NeuroPace, which is an introduction to what you're talking about, neuromodulation. Because let's say you've isolated your seizure focus and it's a small area, and you're like, we should be able to target it. But it actually now has function that's you can't recover well from. It could be part of the brain that is very involved in understanding language. Well, you're not helping somebody by curing their seizures, but then they can't understand conversations well around them. They can't read well. Then you say, we've targeted it, but we can't remove it. Now we have the RNS, and one of the ways it's being deployed
RNS?
Is the responsive neurostimulation system. And right now there is one vendor called NeuroPace. And here a device actually a tray will replace part of the skull, and within there will be a battery and a small computer and electrodes that go into the brain. And what we've known for decades, believe it or not, is that if you detect a seizure, you can put an electrical stimulation and sometimes, and most of the time, stop the seizure. And in fact, we do that now, and we're testing brain function with implanted electrodes, but that's not portable. We have all equipment around the bed. But now you can actually get data from the computer that's put in, see EEGs, and actually work with the program to actually make it recognize seizures better and more effective. And we see that over time, and the reason it's called neuromodulation is that it learns to, without us programming and changing parameters, to recognize seizures better, stimulate, hopefully interrupt those seizures. But what we have found is over months to even it can be a year or more, fewer and fewer seizures occur. It's almost like the stimulation seems to change that network's behavior, that firing pattern, to have fewer seizures. Now, again, is this a technology that's new? It's something we've known about for actually almost 50 years. You're probably, everybody in the audience is familiar with the author Michael Crichton, who wrote The Andromeda Strain, Jurassic Park, and many of those. Yeah. His second novel was called The Terminal Man, which was the character in it had epilepsy, and they knew, and it was a computer that would stimulate in his brain, but obviously not freestanding. So, but we knew about this in animal models back then. And, again, he was a brilliant writer, and actually most people didn't know he was an MD PhD. Okay. And he, took it to another level. But in fact, even then, this was something we talked about, but it took time for both battery and computer technology to get to the point where we could do it. Because you probably have heard, like, your average iPhone now has more computing power than the computers that sent the first man to the moon in '69. So, I mean, again, this is where technology really helps us and brings something that we've wanted to bring to patient care for decades, and now it's practical.
So this sounds all like it's creating a lot of hope.
Yes.
And improvement in treatment and management of the disorder.
Now, just for the completeness of some of the discussion, what's already available as neuromodulation. The first device really that came out that way was the vagus nerve stimulator. And most people don't realize it's been around since 1997.
Okay, so what's new about it now?
Well, the most recent thing they've done is not only just making it smaller, so it makes it more readily accessible to smaller patients, but it can't do seizure detection based on brain activity. Just to revisit what the vagus nerve stimulator is, it's a generator that looks like a pacemaker that we program, which stimulates, and it hooks up to the left vagus nerve, which the left goes into the brain, the right goes out. And we use natural pathways to stimulate and change some of those again. Epilepsy firing networks, again, no more than 10% become seizure-free, but the majority of them a reduction of 2/3 or more. And again, when you go back to goals of care, for some families who have a very affected family member where it's a lot of developmental issues and can have 10, 20, even 30 or more seizures a day.
Oh, gosh.
If you can bring that down to single digits, they're more alert, they can be more, I mean, you know, I've had parents tell me my child suddenly can look at me and recognize me. You know, for a mother who's had a multi-handicapped child, just that they are now alert enough that they can look at them, make eye contact and smile and even hug more, or just engage as a family member is really quite a golden moment, as you could imagine. So again, sometimes not even making people seizure-free, but that relief of a catastrophic burden is worth it. And the vagus nerve stimulator was that game changer as the first. They've improved the technology. I said it couldn't detect seizures through brain activity, but many people at the start of a seizure, they get a heart rate change that's a little bit different than if we were just simply exercising or other things. And it can now pick up heart rate changes and stimulate on the presumption, and that has actually improved seizure reduction. It bumped up their seizure freedom rate from about 6 to 7% to that 10%.
Okay, so it's basically computerizing the brain.
It's using computers to alter networks. The computers controlling the brain, it gets a little bit more frightening to me at some levels as we think about it.
I don't want to scare anybody.
You know, we're not taking control over people. We're not programming their brain to do anything we want, but we're using computers to assist. And the other one that really bears discussion is another technology that's been around but used in a new way, which is the deep brain stimulator. And some of the audience might be familiar, and you might be familiar, that it revolutionized treatment of Parkinson's disease with tremor.
Yes, we found out that
if we target different parts of the thalamus, that can interrupt seizures as well. And right now, we don't know where it should be positioned, but it looks like it's at least as effective as the vagus nerve stimulator, and it works in people who didn't get the response you wanted with the vagus nerve stimulator, and may have advantages in some of those really devastating seizure disorders of childhood. So again, another option where we're making available to children, still finding out where it should be positioned, but things that we didn't think of even 5-6 years ago.
Okay, so a lot of options, a lot of hope. And I want to get this in before we run out of time. I want you to talk about the level of expertise of you and your team in the Child Neurology department. Why should we take our child to WVU Medicine Children's or the
I can't tell you how excited I am to answer your question.
Okay,
so much that I didn't even let you finish the question.
Okay.
Because I wanted to talk about it so much. There is a lot of excitement here. I mean, that's what brought me here. I've been in practice for over 30 years in academia. I've worked with some of the thought leaders in this area. And, again, sometimes we don't even know what's happening in our own backyard. But in fact, through the Rockefeller Neuroscience Institute, a team has been assembled beyond epilepsy that really is world class. And the focus in the last couple of years, maybe a little bit more, has been, we've assembled our team for adults, let's assemble our team for children. And it really attracted me because, again, of that excitement and commitment to providing that highest level of assessment and care. And, the first critical part of that is establishing a leadership structure with thought leaders who are very well known in the area. And that was not me. That was actually Dr. Adelson, who is a very, very well internationally known pediatric neurosurgeon.
We've talked to him before.
And he, again, brought with him a wealth of experience, not just in the surgical arena, but leadership, having built programs like this. And then he went about assembling his team. I have been fortunate enough to be part of that because I wear two hats. I'm coming in to strengthen our team for child neurology, which goes beyond epilepsy, but professionally, my area of interest has been refractory epilepsy, medically resistant epilepsy, and those surgical treatments. I joined someone who Dr. Adelson had already recruited. And what I can tell you that has impressed me is the technology we have available when you talk about the testing really is at that cutting edge. There are maybe one or two research tools not there, but in terms of clinical, there's no gap in what we have available to us. And Dr. Adelson's experience as a surgeon, myself and Dr. Bajor, our experience with doing the assessments, can offer any of those treatments. I would dare say there is really, for what is the most recent care, there is nothing we don't offer. And we have experienced, established people in that.
And you don't have to leave the state.
You don't have to leave the state. I guess I should have just said that right off the bat, but it was implied in the message. We really are at that edge, that cutting edge. And again, it's sometimes we don't always know what's in our own backyard. But what attracted me to it was really this very proactive, very energetic, and dedicated group who really do want to serve the community. And they've been able to, through their efforts and philanthropy, which I can't emphasize gratitude enough for the philanthropy that has come in, particularly the Rockefeller family, to make these opportunities. There has been unprecedented growth, and again, people may not realize it, but in their own backyard is a world-class institution.
Always exciting things going on at the Rockefeller Neuroscience Institute. Okay, right before we go, I always like, this is always my last question. Tell me, what is the most important thing you want our viewers or listeners to know and remember about pediatric epilepsy?
Well, I guess first and foremost, because again, there is that, it's frightening, but for many children, we can assess, we can get them under control. But for those that are frustrated that it's not going well, there are lots of options. This is a time of hope. This is definitely a time of hope. But we do also need to stay mindful that medically resistant epilepsy does have consequences, not just on our ability to be independent. As you become an adult, you can't drive if you're still having seizures. It's much harder to live on your own, to stay employed. So again, be educated. Be familiar, for example, with resources like the Epilepsy Foundation. And again, we should be bringing up those options, but they can be asking these questions as they learn more. Should I be considered for this? Because again, the future is brighter than it's ever been for this patient population.
That's excellent. Thank you so much for sharing all this information and giving us hope. I mean, certainly. There's a lot of things already going on and a lot of things on the horizon. So thank you for sharing that with us. I really appreciate it.
It's been an honor and a pleasure.
Excellent. Well, that brings us to the end of this edition of Live Healthy West Virginia. If you're looking for more information on pediatric epilepsy, visit wvumedicine.org/epilepsy. And to find the latest episode and all episodes of Live Healthy West Virginia, visit wvmetronews.com/podcast or on the all-new West Virginia Metro News TV app. I'm Mary Ravazio Menard, and on behalf of Dr. Morton and everyone at WVU Medicine, thanks for joining us.